Start the
So my name is Laura Donahoe. I'm one of the thoracic surgeons, one of the CTEPH surgeons at Toronto General Hospital. Really, it's very nice to be here. I joined in this session last year and really enjoyed it. So I think we kept it pretty informal last year, sort of plan to do the same this year, but happy to discuss any questions or sort of go over things, and then we can go over whatever questions everybody has.
And I'm Marc Deperot, the other thoracic surgeon doing pulmonary aortectomy in Toronto. And also a great pleasure to be here and to share the platform here with Laura. And as Laura mentioned, last year we had a very good experience to keep it informal, and that gives an opportunity to everyone to participate, which is really what we hope we can achieve.
Do you want to start, Mark, or
whichever you want? Yeah. So I can, maybe I'll give a little bit of background and then we can, go in some of the details that question that you may have. Like so as a background, we started the aortectomy in Toronto like 70 years ago now, 17, and the program has become more and more active, and certainly fulfilled a need that was needed in Canada. And the chance we have is really the ability that we have to work jointly with the PH program in Toronto, as well as the other PH program across the country, which I think overall is quite a unique interaction on the collegiality between all the program and certainly with us. And the other key part in the program is really the ability to have a large number of physicians, nurses on allied health who are very expert in their own field, and it's really the interaction that we have all together that makes the strengths and the success of the program. And Laura and I are really certainly lucky to be able to work with such a great team. And part of our focus has been to make sure also that all our patients are well informed about the surgery. So we've generated some pamphlets that describe some of the characteristic of the disease and the surgery. But this is an area that certainly we can improve on the feedback that we have from patients, patients' family, friends, are very helpful to us in order to make sure that the important information are conveyed to everyone, and that some of the difficulty are addressed. And part of the difficulty is the need to travel quite a long distance for some patients to come to Toronto. So this is always something that is quite potentially a challenge, and we're here to help. But it's always important for us to see how where we can provide additional help on information as well. So I'll let Laura a few words as well, and then we're happy to hear from everyone.
So, the session's about the new research and treatment and advances. And as I'm sure there's three main treatment categories that we think of for CTEPH. There's the medications, there's surgery, and then there's balloon pulmonary angioplasty. And there's different research going on in each of these areas. From a surgical perspective, maybe we'll start there. The surgical technique is fairly standard. So we haven't really changed what we do in terms of the actual surgical technique over the years, but I think what's really changing and sort of constantly adapting is the patients that we operate on. A lot of that has to do with center experience. So we do a lot every year at our center, and I think we do a lot more patients who have disease very far out in the lungs, very distal. And I think compared to probably when Mark started the program 17 years ago, that's been that's one change in the practice of the surgery. One big change too, I think, over the past number of years is doing surgery for patients who don't have pulmonary hypertension, but they have chronic thromboembolic disease. So these patients have evidence of the scar tissue in their pulmonary arteries on the imaging, but they don't have any evidence of pulmonary hypertension, but just having those blockages there causes shortness of breath, and it really impacts a lot of people's lives. So I think we're doing more and more surgery for patients who have chronic thromboembolic disease, or CTED. You know, from one really neat area, and I think we're doing more and more with one of our colleagues, Dr. Sebastian Mayfield, who's an interventional radiologist, and that's the area of balloon pulmonary angioplasty. So the idea behind it is that, you know, CTEPH is caused by this chronic scar tissue, these chronic blockages. And the ideal situation is when we can go in and physically remove them and open up the arteries. But there's certain situations where that's not possible. So one is if it's really too far out in the lungs, and we don't think we can reach it at surgery. That's becoming less and less common, but it happens. Another is in patients who've already had surgery. You know, oftentimes the result, I would say almost always, it's never like, it's not, you will likely always find something if you do follow-up CAT scans. Like, it's very difficult to clear out every single little blockage in all of the arteries. And some patients who have pulmonary hypertension after surgery, they go for this balloon treatment to stretch open those areas that are left over, because you can only do the surgery once. Another area is people who aren't candidates for surgery because they have too many other medical problems, or they just don't want surgery. And these are sort of the main groups. And I think, you know, we're learning more and more. We're doing more and more patients with balloon pulmonary angioplasty, and we're trying to, you know, look at very individualized treatment for each patient. And so that's really a neat and expanding area. Do you want to add something, Mark? Or?
No, that's great. Yeah, so I think, you know, as I was pointed out, I think what we starting to see increasingly is that all these treatment options really work well together. Like, they're all complementary rather than on alternatives. So they really do work together depending on the level of the disease, on also the, you know, the severity of the pulmonary hypertension. We know that as the disease progresses, some of the damage become less and less reversible despite the surgery. On the BPA, on medical therapy, kind of complement the benefit of the surgery for the very long term. But the part that we are trying to do is really to catch the disease as much as possible at an early stage. That's really where the results of the surgery particularly, but also BPA have the best chance of being active, on that we can prevent the progression of the disease and on some of the damage that may become less reversible, even if the cast of chronic scar tissue from the blood clot is removed.
Another area, so I don't know if you want to talk a little bit about medications. That's sort of less my area of expertise in terms of the new research or advances in use of the medications, but do you want to comment on that, Mark? Or?
Yeah, so the medication so far, the main one that is approved is the Odempos, and I think now it's approved across the country. BC was the last province, I think, that had some limitation, but this is something that we don't, or that is certainly important for us to hear from some of you, because I know that some of the difficulty has been, even in Ontario or in Ontario as well, has been to access the medications. So even though it's approved, sometimes the access may be difficult. So certainly for us, it'll be beneficial to hear from each of you if you had some difficulty. And our goal is also to help from that perspective. So the Odempos is the main one. There are some other ones that are being tested on have shown some success in some of the studies, but none of them have really translated into a formal approval at this stage. But there are other options that are hopefully going to come up over time. But some of these medications may be accessed from compassionate care on some specific release, but in general, the Odempos so far is still the main one.
I guess one final area of research, or there's lots of areas, but another area of research that's being done is looking at imaging to diagnose Dtf. And one of the big problems is that because it has been a more rare disease, a lot of people and radiologists aren't used to picking up the images on the CAT scans. So, and that's really the way that's like one of our main tests that we use to diagnose Dtf. And so it's not uncommon that we have patients who've had CT scans from other hospitals and they're reported as being normal just because the radiologist doesn't have that specific expertise in it. And so we have one specific radiologist, Dr. Michael McInnes, who's doing a lot of research on, being really accurate with the imaging. One issue that's we've had in the past with CTEPH surgery is that when we do the surgery, we find that there's what we saw in the CAT scan can be different than what we actually see at the time of surgery. So oftentimes we see more disease at surgery than we saw in the CAT scan. And he's working at kind of looking at that comparison and making sure we have really accurate labels for where the disease was at the time of surgery, like how far out in the lung. There's interesting, the traditional imaging techniques we use are the CAT scan. The first imaging, I think, was the pulmonary angiogram, which is like an active test where the radiologist goes in and shoots some dye and then takes pictures as the dye is being shot in. So different than a CAT scan. I actually find those very hard to interpret, just not having the experience. We don't really use it as much anymore. But there's a lot of really neat new imaging that our radiologists are working on. Looking at, iodine perfusion. So where the parts of the lungs that are actually not getting blood flow, based on where the iodine mapping is, where it goes in the lungs and where it doesn't go. And we can say, oh, that looks like there's not a lot of blood flow going to that part of the lung. And so it's really neat stuff going on in terms of imaging. We're also, one of our radiologists is also doing a study looking at the heart and MRIs. So we do CTEPH surgery because we hope that afterwards, and almost always afterwards, things are better. So the heart improves, the pulmonary hypertension, the blood pressure goes down, and the right side of the heart recovers. And a neat way to tell that is to look at MRIs of the heart before and after surgery. And so lots of research being done in that area as well.
Mm-hmm.
Any questions so far? We can get into more detail in any of these topics. We just thought we'd do like an overview first, and then we can discuss each in more detail if that's what people would like. Or
no questions, no one's popping in.
one of the things I wanted to mention was about the practicality of all of this. And I think this is one difficulty that we have in Canada, being such a big geographical country, but a relatively small population. And in Toronto, we're the largest center for CTEPH surgery in Canada. There's a few other places that do it. But what that means is that, to have access to these treatments, then, as I'm sure you have to travel to Toronto. For surgery, it's, we say at least minimum of 2 weeks. It's often a lot longer, not a lot longer. It's often longer, sometimes a lot longer. But what can be difficult is for things like the balloon pulmonary angioplasty is just that the schedule that it requires, is a little bit more intensive. So we actually, just a couple of years ago, started opening up this treatment to patients outside of Ontario. And basically what happens is that the person comes to our hospital, has the treatment by Dr. Mayfield, and then stays for a few days. So it's like a few days stay in hospital and then goes home, and then he redoes the treatment again a couple of weeks later. We've modified this a little bit to try to speed it up, so leave less time between the treatments for patients who are from out of province. But traditionally it was 4 to 6 weeks later, and he would repeat another treatment, and this might go on 3 or 4 times. So one big part of our practice is working on the logistics of all of this and making sure that everyone across the country has access to these treatments, despite the fact that we have all these barriers, to physical barriers and stuff.
Brad had a message question. What are the most common side effects of Odempos? ADEMPAS.
So the Odempos is the primary medical treatment for the CTEPH.
Okay.
And it's used also for pulmonary arterial hypertension, but not as much. But the main side effects is the effect on the systemic blood pressure. And that's why the medication has to be started at a very low rate and then very slowly increased over several weeks in order to make sure that the blood pressure is maintained within an adequate range. And then once the dose or the therapeutic dose is achieved, then some of the side effects I've noticed most is some effect on the stomach, some nausea, on kind of fulfilling. That's one of the side effects that I've seen more frequently, and then can create a bit of swelling of the legs as well. So these are the main side effects that I've seen. There are some less frequent ones, but these medications are delivered by the PH physician. So once the patients go on medical treatment, they are more closely followed by the PH, pulmonary hypertension physicians. And we do see them see the patient less often. But in general, when we initiate it, that's some of the main side effects that we've seen, particularly the nausea, I would say.
Oh, yeah. And Rebecca said, it's not so much of a question, but an appreciation of the acknowledgement that there are patients who can't have surgery for whatever reason. And it gives her hope that there are other different medications being investigated. As she adds more medications for other conditions, she's worried about her Odempos being effective.
Yeah, that's where the balloon pulmonary angioplasty has fulfilled an important benefit. It is often patients who are candidate for the balloon angioplasty, the BPA, will start on medical treatment and then will go on to have the BPA. So that's really an opportunity for a number of patients. So it depends a little bit of where the disease is located. So if it's very proximal, the balloon are not effective because the vessels are too large. The vessel needs to be damaged or stenosed in the level where it's only a few millimeters. That's certainly an option for a number of patients. And then there's still research in order to find new medical treatment, and there are still some studies that are looking at some of the medications that are used for pulmonary arterial hypertension to see if they can be combined with the Odempos in order to optimize the benefit of Odempos, so to have combined medical therapy as well. So that's probably where the benefit is most. But a lot of that so far is done as part of clinical trials.
Maureen has her hand up.
So you were talking about when the people from out of country or out of province come in, you kind of speed up the BPAs. Have you seen any difference in the response to the patients? Do they do better? Do they do worse, having more BPAs quicker than the traditional way?
So far, not directly. We probably haven't done enough to really be able to compare formally, one to the other. But so far, there hasn't been any difference that we could tease out. The reason to space the treatment was to some degree a safety mechanism as well. So the goal or the risk with the BPA is to reopen some of the arteries, and then the lung that is starting to have flow again can get damaged from the high pressure potentially. And then if there is a damaged component of the lung, then we have to give enough time for that part to heal before BPA can be processed further. So part of the goal was to slowly do the PPA relatively slowly in order to make sure there is no damage, on if there is, that there is enough time to heal. But as the BPA experience increases, we see less and less of the damage because the quality of the BPA improves on the technique as to how many vessels can be reopened safely without creating any damage, starting to be more and more known. So that time frame of a month or 4 6 weeks between each procedure is actually not as necessary from a safety perspective on if there was any risk or any damage during that kind of fast course, then it can always be stopped and then postponed to be restarted at a later time. But the goal of the separation, to some degree, at least during the first few sessions, was to decrease the risk. Now what is difficult to predict with the BPA is how much the pressure is going to come down and how quickly. So, one of the benefit potentially to do it at a faster pace initially is to be able to see how much benefit there is, and then you can give some time for the benefit to take place completely, and then reschedule a series of procedure later on. But certainly the increasing experience shows that you have to do at least 4 to 6 BPA. Or even potentially a bit more to start having a clear benefit. So doing them relatively early on has some advantage from that perspective, and then wait to see what the benefit is, as long as it can be done safely. So there's still a lot of evolution, I would say, in the ability to predict the BPA, on the quality of the BPA, on the safety of the BPA that has happened over the past 3-4 years. In our experience, the BPA really, and I think that's what is increasingly being seen in other centers as well, is that the BPA has a very great potential benefit when it's combined with surgery, because the two are quite complementary. The limit of the surgery is really when you get to the vessel that are 2-3 millimeters. On the BPA, starting to be effective in when these vessels are being damaged. And the problem with the BPA is that if you have a lot of vessels that are affected, it's hard. It takes a lot of sessions to be able to bring the pressure down. Well, if you do them after surgery, you can shorten the number of sessions that is needed, and it's really optimizing the results. The nice part about the BPA is that the timing after the surgery can be really chosen based on how the patient is doing. So increasingly, we are looking at it as a complementary approach to the surgery, particularly when the very small vessels are being affected.
Okay. What happens to the parts of the lung that aren't actually getting the blood flow anymore?
So the vessels that are narrowed gets damaged. So the problem with the CTEPH, and that's why it's important to pick up the disease early. Part of the goal to pick up the disease early is to make sure the heart is still well adapted to the pulmonary hypertension, so that decreases the risk of the surgery. But also within the lung, there are increasing damage that occurs as from the cast of the scar tissue. The vessels that are blocked gets damaged because there is not enough blood beyond it. So you have what we call the bronchial circulation, which is the fetal circulation that brings oxygen to the lung, so the lung doesn't suffer from the lack of oxygen. But that fetal circulation carry the same blood pressure as the blood pressure that goes in the rest of the body. So the blood pressure is actually very high for the lung, which damages that part of the lung when there is no blood from the normal artery with the blockage. So that's one way the lung gets damaged. And then the blood that doesn't circulate in that part of the lung is being pushed in the part of the lung when there is no blockage. So the part of the lung when there is no blockage sees excessive amount of blood, and that excessive amount of blood creates what we call a shear stress. So there is high pressure just because all the blood is circulating in only one part or a few parts of the lung, and that also generate damage. So there are two ways the lung gets damaged. Either there's not enough blood or there's too much blood, and both eventually leads to more and more damage and aggravate the pulmonary hypertension. And that damage is fully reversible when it's at an early stage, but as the disease progresses, the damage is less and less reversible. And that's why the benefit of the surgery is becoming less predictable as the disease is more advanced, because you don't know how much of the damage is fixed. And again, that's where the medical therapy and the BPA can help to some degree. But the goal is really the ability to pick up the the disease at an early stage. So the heart is well adapted to the situation, and also the lung doesn't have secondary damage that is permanent.
Okay, so the part that's getting damaged, is it dying per se?
No, it doesn't die because the oxygen still comes. The part of the lung. So basically, the lung suffers because there is not enough oxygen. When there's a blood clot, the flow of blood is obstructed. So that part of the lung suffers from the lack of oxygen. And then there is oxygen that is being brought to that part of the lung from the fetal circulation. So the lung eventually will recover because the oxygen eventually is being brought by these new vessels. But the new vessels are not normal. So that's how the damage gets created, although the lung doesn't die because the oxygen is there.
There's a real spectrum of disease too. So that's why, we're talking about all these different treatments because every patient's very, very different. So we have to take each patient sort of individualized and say, where is their disease? How much is there? Is there a lot of blockages, scar tissue? Is it very close into the heart? Is it far out in the lungs? How bad is the pulmonary hypertension? How long have they had this for? There's all these different factors that go in, and part of that is determining how much of this is reversible, because the point of doing surgery is to reverse whatever changes have happened. And that's what, that's our goal with it. So, some people who have disease very far out in the lungs, if they've been on medication for a long time, then they may be less likely to benefit from surgery because their changes are less reversible, things like that. So.
Do you find a lot of patients have to do more surgery? Will it come back?
Good question. So it won't come back, but people have to stay on blood thinners forever. So, it's not a guarantee. As long as patients stay on blood thinners, it's unlikely that they're going to get fresh blood clots. I think usually more of the issue is just having some leftover scar tissue that we weren't able to remove, or, even if we've removed it all, they have leftover pulmonary hypertension. And then they often need another treatment. We don't do surgery again, though, because it's a very big surgery to start off with. And then once you've gone into the artery and sort of pulled out that scar tissue, it's not safe to go in again because you lose those layers to find the proper layers. So for those people, that's where we would do balloon pulmonary angioplasty or medications or both. That's sort of what we're exploring more and more. The usual route is to do medications plus or minus the BPA, but we're learning a lot more about that.
The other part that we're looking at a bit more closely is also the type of blood thinner. So there's a lot of new blood thinner that have come over the past 10 years. On these blood thinner have been used in the what we call the acute blood clot. So when the clot is fresh and will resolve. Once a clot is organized and can lead to CTEPH in a small proportion of patients, the medication seems to still work, but after the surgery, there may be a period of time when these new medications don't work as well. So that's something that we are looking at to make sure that the blood thinning is adequate to prevent the disease from coming back. The main part really when we look at the diagnosis on the surgery is really to make sure of the diagnosis. On the, Laura mentioned that the CT scan now has become a very important way to make the diagnosis and to localize where the abnormalities are. And we don't do too many pulmonary angiogram anymore, which is no more invasive. And require a lot of expertise from the radiologists who do it. But the CT scan gives us a lot of information on the quality of the CT scan has really improved over the years in order to be able to look at very thin arteries. But the quality of the CT scan is really critical in order to make the diagnosis and to plan the surgery on. That's an area that we're also trying to homogenize across the different centers to make sure that the need for the different characteristic of the scans are fulfilled with one scan. So that's a lot of that work is done by a radiologist, Dr. McInnes. But the CT scan really has changed the ability to make the diagnosis and to plan the surgery to a very large extent. On the CT scan also is important in patients who have a fresh blood clot. So if somebody has what we call an acute pulmonary emboli, so the CTEPH is the long-term complication from an acute emboli when it becomes chronic and leads to pulmonary hypertension. But what we've realized, sorry, is that the CTEPH is often already there during the acute component of the blood clot. So when the blood clot presents the first time, there are features of the CT scan suggesting that the CTEPH may already be there. And these are the patients that needs to be picked up, because if we can suspect that the CTEPH is there during the acute presentation, that means we can monitor the patient for a few months as the blood thinner is started, and then if there is clearly CTEPH, then we can intervene early in the process rather than waiting for more complication from the disease to happen with either more blood clot or more damage to the lungs or heart failure develop before the diagnosis is made. And that's an area that has changed a lot over the past few years, and that's also why we're starting to see more and more patients who don't have pulmonary hypertension, is that the disease is picked up earlier on the treatment effect is certainly a lot better. And not everybody needs treatment, and some patients just need to be monitored, but at least we know what the situation is up front.
Rebecca noted, and then you add in the people who have antiphospholipid antibody syndrome that can still clot even while on a therapeutic dose of blood thinners. That's me. Yes, very good point. We're very cautious after surgery. There's standard doses for blood thinners, but definitely people, especially people with antiphospholipid antibody syndrome or other situations where they are more prone to form clots. We have to be very careful with monitoring the blood thinners because despite our best efforts, sometimes people do get some fresh blood clots after surgery. So we're really trying to prevent that.
Yeah, that's a very important point. Yeah, we tend to delay the surgery until we're sure that the blood thinners are working well to make sure that there's no risk after the surgery when we go back to the blood thinner.
Any other questions? One thing I wanted to mention was just when we talked about the imaging, and there's sort of two parts of establishing the diagnosis. One is finding the disease on the imaging, so using our CAT scans or sometimes our pulmonary angiograms, but then also determining how much of an effect it's having on each person. So, does the person have pulmonary hypertension? So we do our echocardiograms to look at the heart, and then we do the right heart cath where the cardiologist or radiologist actually go in and measure the direct blood pressures. And then, more and more, especially for patients who on those two tests don't have pulmonary hypertension, we're doing two other things. So one is The right heart cath usually is done just with somebody lying still on a table, and it's just at rest. So when you're not doing any exercise at all, what is the blood pressure in your lungs? But for the people who have CTED, so we see that they have scar tissue on their CAT scan, but they don't have pulmonary hypertension when they're resting. What we do is one of our cardiologists, Dr. Susanna Mack, does a study, a right heart cath with exercise. So she actually does it at rest, but then has people exercise and measures the blood pressure in the lungs, because sometimes in these patients, it actually goes up during exercise abnormally. So that's really a neat area that we're using more and more to help in our investigations of these people who are a little bit less straightforward. And then another area is cardiopulmonary exercise testing. So like a treadmill test or an exercise test where we look and see, because a lot of patients we see have multiple medical problems. So it's not just, it's almost never just one thing, very straightforward. It's often, sometimes patients have been longtime smokers and they have COPD or they have other issues. So what we do is with this cardiopulmonary exercise test is we can try to sort out how much of the symptoms are from the actual chronic thromboembolic disease, the scar tissue, versus from something else, maybe to do with the lungs or the heart otherwise. And this all goes along with just it being really important that we know that when we do surgery, we think it would benefit. And so we want to know that the scar tissue is actually causing a problem.
What's the most common kind of comorbidity here?
Good question. A lot of patients are overweight. I would say that's one of the most common ones, like quite overweight, which I think has a lot of, it's probably potentially a cause and an effect. So it's hard to say exactly that it's causing the blood clots, but definitely when patients are very short of breath and they have high blood pressure, or like pulmonary hypertension, it's very difficult to exercise and difficult to lose weight. So that is definitely an effect of having CTEPH for sure. So that's a big one, I would say. And a lot of people have things like antiphospholipid antibody syndrome or another clotting disorder where and that's the reason why they get the CTEPH. Sickle cell anemia, we've had a few patients. Yeah.
And would you say the priorities are on sort of better diagnosis or finding ways to kind of focus the treatments in terms of?
Good question.
Mm-hmm.
Mark, do you want to?
Sorry, what was the question?
I was just wondering, whether it's sort of the main primary focus or some of the focuses are, whether it's sort of the diagnosis to kind of figure out all these different variations, or on sort of the treatment, or maybe it's split.
Yeah,
it sounds like you're kind of tailoring treatments for each patient and getting much more.
So yeah, certainly there is importance on both sides, to optimize the treatment. Certainly it's still very important. What we are seeing certainly with the current treatment, the results, certainly have improved a lot on the surgery. Certainly leads to, excellent long-term benefits. So, we're finding the medical part mostly for patients who particularly are not able to have surgery. That's certainly an area that requires a lot of focus. On the other part is really on the diagnosis, because this is really the main pulmonary cause of pulmonary hypertension that is completely curable as long as you pick it up at an early stage. So a lot of the focus has been to really capture the patients who have the disease, and also to try increasingly to diagnose the disease at an earlier stage. And that's where the diagnosis or the suspicion of possible CTEPH at the time of an acute blood clot with no prior history of blood clot is quite important, because we can potentially monitor patients who are no signs of being at risk of CTEPH and then pick it up early in the process and be much more effective in curing the disease. So that's an area that has really been requiring a lot of focus on. And if you look at the number of patients who have an acute blood clot versus the number of patients who have CTEPH, it seems that there's still a large discrepancy in the number of patients that are diagnosed with CTEPH, suggesting that there's still a lot of patients who have CTEPH who are never diagnosed. on chance of being cured and certainly to improve their symptoms. What we've realized also, as we do see patients with less pulmonary hypertension, the CTEPH patients, we do realize that that the cause of the shortness of breath is the pulmonary hypertension, but it's also having part of the lung non-functioning. Patients get very short of breath even without pulmonary hypertension, and these patients may suffer from a lot of long-term complication from being short of breath. Part of it is the weight gain that Laura described, but part of it is also the lack of activity eventually can lead to pneumonia and some other complication that may become life-threatening on these patients may never be diagnosed with their CTEPH. So these are potentially a large group of patients that are not yet diagnosed but a lot of these patients will have a history of blood clot at some point in their life, and that's where we have shifted some of the focus is really to tease out the diagnosis of CTEPH at the time of diagnosis of blood clot. So.
Anyone else have questions?
Sorry. Just going to say a lot is like education of physicians as well across the country to recognize it and think about it and have it, if somebody presents, have it in the back of your mind that this could be a possibility.
I think that's generally just most of the rare disease and pulmonary hypertension. That's what we're finding. That's a big campaign we have. Yeah. Would you say that's the biggest barrier?
It's one of them, certainly I think in Canada, we're quite fortunate because we have a lot of, very excellent pulmonary hypertension program on every pulmonary hypertension physician in Canada is very well aware of the possibility of CTEPH and the diagnosis of CTEPH is really looked at carefully when somebody is diagnosed with pulmonary hypertension, but other countries like the US and some other countries, the CTEPH diagnosis is not always looked at optimally, and patients may be labeled as pulmonary hypertension, group 1 or group 3. On the group 4, the CTEPH group may not be looked at as accurately, and that reflects the fact that the quality of the CT scan has to be very optimal in order to make the diagnosis. And the diagnosis may be missed because the scan is not optimal or because the radiologist is not aware of the very subtle findings of CTEPH on the CT scan. We still use the VQ scan to a large degree to rule in or rule out the disease, but not every center in the US do a VQ scan when somebody is diagnosed with pulmonary hypertension. So the ability to really tease out the diagnosis even in patients with pulmonary hypertension is still an area that requires a lot of focus on to make sure that the disease is picked up when it is there, because again, that's really the only potential cause of pulmonary hypertension that is truly curable compared to the other type.
As a patient from a small town with a PH diagnosis, I'm finding a lot of times I run into doctors and they're like, "You're on oxygen, what's going on?" I'm like, "I have PH or pulmonary hypertension," and they don't know what it is, or they remember hearing about it in school, but they never touch it again, right? There's just not that much because we're so rare. So as a patient, there's a lot of education on our side, teaching doctors about it. So
that's really interesting. Yeah, I guess from the doctor perspective, like that must be very difficult, like to have to feel like you have to do that, but important because you're right. Like unfortunately, there's only so much that everybody can know, and especially generalists. Like it's really hard to know about all these different conditions, but it's important to because the more education you do, and then they'll learn from there and recognize it in the next patient they see.
I'm fortunate that my GP did that. She's done some more research on it and stuff so that she can help me out a little bit more too. So.
Oh, great.
Yeah, that's great. Yeah, certainly. That's a lot of the education is done, that way by kind of osmosis between, the physician learn as they see, the diagnosis and learn from the patients and the specialists. So, the more there's still a lot of education that needs to be done. Yeah, definitely, that's very important point.
And I would imagine on both sides, even from the patients too, because so often you hear like, "Oh, I'm just middle age, or I'm out of shape, or I'm da, 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 da. Yeah, when we did the last survey, we found like the overall message is a move, but we found like a whole clump of people got diagnosed just in PH generally really quick, and then there's a whole pile that took forever.
Mhm.
And where it's hard to break down is where it got from actually getting into the system versus once you're in the system, how long does it take to get a diagnosis? It's two parts, right? And that first part, if you never go see the doctor until you're kind of well on, then.
And we do find that a lot of patients will say, like, they'll be referred, or their history will be that they've had shortness of breath for 6 months. But if you really ask them, they'll say, well, it probably started 5 years ago and it's subtle or whatever. Like, so oftentimes it's been going on for a really long time for people.
Yeah. And how fast would you say it kind of sets on for CTEPH, like for the clots themselves, sort of?
I think we don't know.
You don't know?
Yeah, like it's very variable. I mean, some patients, it can progress over a few months, but as I mentioned, often, even after the surgery, patients, sometimes tell us they feel better than they felt in 10 years. So the disease really can start at a very, slow pace. On patients just adapt, and all of us that, you kind of do a bit less, and you kind of adapt, instead of going up the stairs, you take the elevator. Instead of, going for your, activity, you kind of slow down and you put your own age. But, when things get to a point that it becomes difficult to do the daily activity, then the attention is being focused, but the diagnosis is made, but the disease does potentially progress over potentially many years. But the CTEPH is quite difficult to predict, I would say, because sometimes things go slowly and suddenly there is an abrupt progression, and that's often when patients may be labeled as having an acute pulmonary emboli because they found the clot at the time, but some of the clot have been there for months or years. But there's still that rapid progression that looks like a new fresh blood clot, while the disease has been kind of slow going for a long time. So there is a little bit of situation potentially in the evolution, which is probably more true for CTEPH than the PH cause.
Peggy, did you have a question?
Yes, hi. I have a question. Like, I had PTE surgery in 2015. I had it in Montreal. I'm from Newfoundland. So basically, I got sick, went to the hospital, and was diagnosed a year later when I was referred to a hematologist. And basically the hematologist had done his internship with a CTEPH clinic. And when he saw some of my scans, when he saw me, I was just after the week before I'd gone to see a pulmonologist, and he saw some of my scans, and basically he's like, you have CTEPH. And I was kind of like, what are you talking about? Like, what is that? And, so he knew I had to go, and so he reached out to the doctors that he had done his internship with, and I had gone to Montreal. So anyway, I had my surgery in 2015. And since then, I've been going back and forth to Montreal for checkups because there is no CTEPH clinic in Newfoundland. And at the time, there was no pulmonary hypertension clinic. But now there is one, and there has been for a number of years. So Lita, the nurse at the CTEPH clinic, used to keep saying to me, reach out to them. And I said, well, what for? If I'm coming here, what do I need to reach out to them for? So anyway, my pulmonologist has gone away. And so now I was referred to the clinic. So I'm there now. And that's where I'm seen all the time in Newfoundland. And like I just kind of feel like I'm not sure if that's the only place I should be going. Like, how important is it, or is it important that I should be going to the CTEPH clinic as opposed to the pulmonary hypertension clinic, or both?
It's a great question. So I would say, I think probably most patients in Canada are followed at pulmonary hypertension clinics. So because we have people who come from all over the place, a lot of times after we do their surgery, they're followed just at their home clinics. So I think the fact that you're at a pulmonary hypertension clinic is most important. The main thing is, you have to have follow-up. So we typically do yearly echoes and we do 6-minute walk tests. And we're starting to do some more imaging like repeat CAT scans or right heart caths just to check the blood pressure in the lungs. But I think the main thing is just that, like, it's good that you're at a PH clinic. And the main thing is just like, if your symptoms get worse or something changes, then that's really when it's important to be reassessed by somebody who has a particular interest in CTEPH. But otherwise, like if everything's good, I think you're probably fine to just keep going with your PH clinic.
Okay, but should, like, the reason I never went, I haven't gone back to the CTEPH clinic was because of pandemic.
Mm-hmm.
I wasn't going to travel. And that, so it's been like 2.5 years. So I'm sure if I reached out to them, they'd be like, you should come in. Mm-hmm. Like, is there any need or, like, I don't know.
I think it depends on what tests your PH doctor is doing. Like if you're having echoes or you're having like yearly follow-up tests at the PH clinic, I think that's probably most important. You could reach out to them though and see what they think. They might say just follow up with your local clinic, but doesn't hurt to reach out for sure.
Okay. Thank you.
That helps.
I agree with Laura, and I think the most important part is to be followed. I don't necessarily think as well that it has to be CTEPH, but a CTEPH clinic. But I think the importance is really to be followed in the long term. And whoever does the follow up, but as long as somebody is being followed, it should be appropriate to cover the need and to monitor the situation. I think.
Peggy, can I answer as another patient? So Dr. Perot and Dr. Donahue did my surgery in Ontario, in Toronto. I live in Alberta and I see my PH clinic here. And my doctor, when he thought BPAs might be a possibility, he's the one who followed up with the CTEPH clinic for me. I've never seen the doctors who did my surgery again, other than things like this. I just follow up with my regular PH clinic, and then if they see something that they think should be seen more, then they'll send it off to the CTEPHs, more specialist people.
And that's usually what happens because we, with just having patients all over the place, we think it's probably better for people to be followed in their home programs, and then people reach out to us if there's a change. Yeah, but
I'm happy with the clinic that I'm in right now. But when I first reached out to him, because Lita, who was the nurse practitioner in Montreal, she kept, asking me, did you reach out to them? Did you reach out? And I finally did. And I was told by the nurse who I was speaking with, she said, oh, well, there's no need for you to come to see us because you're being seen by Dr. So-and-so who's in the same, like his office is next door. And I said, oh, okay. All right. So, but when that doctor had left and I was referred, when I was there, it's like, oh, Peggy's one of the patients who kind of fell through the cracks. And I went, excuse me? I said, you told me I didn't need to be here. So,
I think it depends, whatever you're comfortable with. Like if you're more comfortable going back to Montreal, I'm sure they'd be happy to have you, so you could reach out. It's just, it's a comfort level too, for sure.
Yeah. Yeah. So I just didn't know then if I really, if just, I don't know. But you answered my question, so I'm fine.
Okay. Great.
But I think that brings up a good point that you should feel comfortable asking questions and just kind of bring that kind of engagement.
For sure.
Yeah. I think that's the key thing. All right. Well, we're just at 3 o'clock, conscious of the time. So did anyone have any last minute questions? Okay. Well, if you think of something, you can email me at dfisher@phacanada.ca or anyone at PHA Canada, and we'll kind of get the answers for you and wrap that up as well. So I want to thank you, both our esteemed doctors, for doing the session. It's great. And thanks everyone for coming, and hope you see some of the other cool sessions this Saturday, next Saturday, and some of the stuff during the week. And great. All right.
Thanks, everybody.
Thank you.
Everyone, thank you for getting it.
Thank you.
Anya. Thank you very much.
Bye.
Good afternoon. Bye-bye.
Bye.